Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled Omicron Variant Effects on Treatments for COVID-19. During this podcast, Dr. Arthur Kim, Associate Professor at Harvard Medical School, Director, Viral Hepatitis Clinic in the Division of Infectious Diseases, and COVID-19 Medical Director in the Department of Medicine at Massachusetts General Hospital in Boston, discusses treatment modalities for COVID-19 in the setting of the Omicron variant. For more information about Dr. Kim and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Kim has to say about the effects of the Omicron variant on treatments for COVID-19.
Good morning, good afternoon, or good evening, depending on the time zone in which you're joining. I just wanted to thank you for using some of your valuable time to join this webinar. And I hope that it is useful to you. And we also hope to have a robust time for questions after the presentation. So I'm sure all of you are in parts of the world where the Omicron variant has emerged and struck in the past month or two, and it has been quite a remarkable time for all of us as case counts rose, hospitalizations have risen. And what we saw when the Omicron variant was first established is just the remarkable differences in its spike protein, and that's shown here on the left. And this accounts for much of the immune evasion from previous vaccine responses, although vaccines are still effective at blunting the effects of Omicron. But just examining the spike protein with greater than 30 changes from the wild type, as well as you can see, even from Delta, there are so many changes in the spike protein, that this raised multiple concerns for therapeutics as well. When one looks at small molecules and what they target, the antiviral that we'll review in a moment, these target various elements of the replicase, and whether it's the protease or the polymerase, the changes in Omicron, fortunately, were fewer and also less likely to cause problems with activity of those agents. And so with that said, the low biologic plausibility based on the sequence for reduced susceptibility to the antiviral agents such as molnupiravir, nirmatrelvir, or remdesivir. Further work from press releases and other preprints that are being seen, we know that the various Omicron isolates reveal mutations that are not expected to alter the RNA polymerase compared to previous variants. And thus, basically, these are expected to be active against the Omicron variant of concern. And so moving to some preprint data, again, not peer-reviewed, but in this time, we are all looking for information that can be useful for us as we make therapeutic decisions. Molnupiravir, nirmatrelvir, and remdesivir in this assay retained their activity against Omicron, and you can see the EC50s here. There are some data points in some of these assays that are missing for the various agents, but here what you're seeing is GS441524, which is a prodrug related to remdesivir, and you can see remdesivir here with the low EC50s that are preserved, again with Omicron. The other agents are shown as we move through, and fortunately Omicron is really not substantially different from other variants. And so this so far has retained our confidence in at least the activity of these agents against Omicron. However, given that it is the spike protein, which is the target for monoclonal antibodies, there's much more concern about these agents, which in the United States have been authorized under emergency use. And thus, one aspect is that each of the individual antibodies in various either cocktails or used alone, bind different areas of the spike protein. And so there's the receptor binding domain where ACE2 and the spike protein interact, and that is a great place to interrupt the virus in many ways. But unfortunately, there's potential there for mutations. Whereas the sotrovimab, which was originally derived from someone recovered from SARS-CoV-1, had activity against multiple coronaviruses and targeted a different epitope in the spike protein. And thus, the approaches so far have been combining monoclonal antibodies can be helpful to increase the likelihood that these are active against various variants. But also the concept that if you can target a conserved epitope, that the virus itself may have a different threshold to mutate around it, and thus the barrier to resistance can be different. And so what have we learned, again, from preprints, and these preprints have begun to be published as well. But this is a experiment looking at the monoclonal antibody neutralization of Delta, which had been previously the predominant variant in at least the United States where I practice, and then versus Omicron. And so if you're not used to looking at these neutralization assays, what you're just seeing on the x-axis are the various concentrations of the drug, and then you see the percent of virus that's neutralized in these in vitro assays. And what you're seeing here is that the bamlanivimab, etesevimab, the casirivimab, imdevimab, as well as regdanvimab, that the orange lines representing Omicron are flat, which is not good from the perspective of neutralizing this virus. What you're seeing highlighted is sotrovimab, where in the box, where sotrovimab, while there's a slight shift, the Omicron variant is still neutralized by this single antibody. What you're seeing in cilgavimab, tixagevimab in the middle is that while there is a substantial shift, there is still retained activity at the higher concentrations that lends hope that this combination, which is currently authorized only as pre-exposure prophylaxis, that this combination may retain activity. So at least there is some hope of clinical efficacy in the Omicron era. I'll also point out that while the shift seems very concerning, it's a couple log at up to 2 to 3 logs, here that the concentration of cilgavimab plus tixagevimab is not too different in terms of where it lies with the Omicron neutralization capacity of sotrovimab in terms of actual concentration. And other studies have shown that cilgavimab plus tixagevimab, that the concentrations remain above these types of inhibitory thresholds for quite some time. This just shows it in a different way, the fold changes. And so again, showing that sotrovimab with 3-fold reduced potency more or less maintains its ability to neutralize in these assays. Again, cilgavimab plus tixagevimab has 200-fold reduced potency, so that is a concerning finding. But again, the concentrations are not that different. So sotrovimab retaining its in vitro activity in another preprint is shown here, and just showing again this 2.8 fold change compared to an ancestral virus. So really, we're seeing repeated experiments, again, demonstrating that sotrovimab can be still effective. And thus, the United States, where I practice, have made the decision to basically withdraw the ability, our ability to deploy the previously used bamlanivimab, etesevimab, the casirivimab, and imdevimab for treatment. And so it really felt like just as Omicron was coming, that we lost 2 of our kind of outer defenses of our arsenal to prevent hospitalizations. So the key points, the key takeaways from the emerging in vitro data, as well as testing the hypothesis of how treatments will be active in the Omicron era. Direct-acting small molecule antivirals are expected to retain activity against Omicron. And in our, since late December in the United States, the nirmatrelvir ritonavir combination, as well as the molnupiravir, are now being deployed. Unfortunately, many monoclonal antibodies have completely lost neutralizing activity against Omicron, with really the main exception of sotrovimab in terms of maintaining or retaining its activity. And we still retain hopes for cilgavimab and tixagevimab. So at this time, that ends the didactic portion of this webinar. We have about half an hour to move into the question and answer session. And I thank you for your attention and for joining this program today.
Wonderful, and thanks to you, Dr. Kim, for that excellent presentation. We've had a number of questions come through from participants, and we encourage our participants to keep those questions coming, and we'll do our best to answer as many as we can in the time remaining. And so our first question comes to us from Rick, who wanted to know if you could discuss breakthrough infections and kind of disease severity after a patient has received the cilgavimab plus tixagevimab monoclonal antibody treatment.
That's a great question, and I think we'll just discuss this real time. I think very rarely have we been in situations where we're presenting programs literally as we're collecting real-time data. So just to sort of level set the audience, the cilgavimab plus tixagevimab is a combination antibody that is used for pre-exposure prophylaxis and is available in the United States for high-risk individuals who do not respond well to vaccines. While it was tested in the high-risk population that include the unvaccinated, it is only authorized for those who have attempted vaccination, really, and also have very high-risk conditions, such as immunocompromise. So in this population, we've also deployed to individuals who are even more immunosuppressed than others. We have a shortage that is predicted to cover only 1% or less of the total eligible population at this time. And so we're really giving it to the most immunocompromised, as you might imagine. These are patients receiving agents that deplete B cells, such as rituximab, or people with chronic lymphocytic leukemia, for instance, on therapy, as well, or people who are transplanted who have rejection and are really severely immunosuppressed. So what this means is that these are patients who are really advised to be careful, and even with this prophylactic approach, are counseled to remain careful. And so thus far, we have yet to see a breakthrough infection at our site. However, I am in touch with other centers who have begun to see this. As you might imagine, because Omicron is so contagious, it is reaching those who have been first receiving these therapies. And so there are very limited information on the outcome so far. I think the patient that I heard about remained an outpatient. So this is a literally evolving field, just as the virus is evolving before our eyes. And so I think we need to learn more and collect as much real-time data as we can.
Great, and thank you for sharing, what you know to date from your own institution and what's out there. And it certainly is an interesting time to be working and living through this with the real-time data constantly coming in. So thank you for addressing that. The next question comes to us from Dwight, who had a question about oral or inhaled remdesivir and whether there was any hope or possibility that we would be seeing oral remdesivir or perhaps inhaled remdesivir formulations coming through anytime soon.
So remdesivir has experienced a bit of a revival in recent months since data for the IV formulation were presented at first the ID Week conference, which is, and then published in the New England Journal last month. And so what that study showed was that 3 days of IV remdesivir administered in the outpatient setting reduced hospitalizations by a similar magnitude as the monoclonal antibodies, as well as with the nirmatrelvir ritonavir combination. So, before that, there was sort of less faith in remdesivir in many parts of the world. Like, does it really do anything? But I think that trial revived a lot of hope that the signal seen in the original remdesivir trial for particularly patients hospitalized on oxygen was real. And there are numerous other studies showing that this agent can help, whether it's in macaques with early treatment, or even starting with some prophylaxis data or that I've seen come through on preprints. So what would really help in the outpatient world would be not 3 days of an IV treatment, which takes a lot of resources, which are often used for other aspects, but as the questioner asked about, oral or inhaled. So these are all in the works, and there's other related compounds to remdesivir that are more orally bioavailable or able to be used. However, I do not see that these will be like immediately deployable, especially for this time frame with Omicron. But of course, the more we have in our arsenal, especially ones that increase our ability to deploy in the outpatient space and are much more easier than even monoclonal treatments, will be helpful to combat future surges.
That's a great point to remember, that the IV formulation, while it's been studied in ambulatory or outpatients, it's not always so easy to deploy or implement in the ambulatory setting, given the need for infusion. And so I had another question come in that piggybacks very well off of the remdesivir discussion that you just had. And this comes from James, who wanted to know if there's any rationale or any data for giving both remdesivir and something like nirmatrelvir concurrently.
Great questions. So this raises the concept of combination antiviral therapy, which we know from the HIV world, from the Hepatitis C world, proved to be critical in terms of controlling or clearing those infections. So at this time, this is an area that has been understudied, and thus it is difficult to recommend that we sort of combine these agents. However, the hypothesis is there, and I think there is concern about emergence of resistance to any antiviral agent, and if also transmissible at that time, that would be of extreme concern. And so could use of any two classes of these agents work in concert to prevent the emergence of that resistance? This is an open question, James, and I at this point, functionally, I would say, just to give some real-time advice, the antibody and the nirmatrelvir ritonavir are an extreme shortage. And so to cover more patients and provide the maximal benefit, not necessarily for the individual patient, since we don't know that those are additive, but to give to two different patients would make sense. Now, would you combine with, say, molnupiravir, which is currently in greater supply? I think that's also unknown. Functionally, what's happening, at least in our state, so far, is that we have patients who are waiting for slots to open up for one of these other agents. And so can we apply within the first 5-day window molnupiravir while they're waiting? And so if they get offered a spot, functionally, they will be getting dual therapy with molnupiravir and let's say, sotrovimab. And so I think at this point, I personally would counsel that they continue the molnupiravir because of the concern of emergence of variants. I hope that answers your question. Again, never before have we had sort of real-time questions that are purely relevant, but that we are just literally trying to gather the data real time to help answer. So look forward to a future webinar where we might have more data.
Absolutely, and thanks for sharing your thoughts and the information that we have to date on these combinations. It certainly is an interesting question and an interesting, potential therapeutic option. So we've had a couple of questions, one from Janice and one from Michelle, linking back to the monoclonal antibodies. And really what they're asking is if a patient has perhaps received something like bamlanivimab and etesevimab, or maybe they were prophylaxed with the tixagevimab and cilgavimab, how long after one of those monoclonal antibody treatments could a patient then receive sotrovimab?
So I think there isn't direct guidance on this issue that I'm aware of, at least contained within the authorization or the package inserts. However, because sotrovimab targets another different site, it is highly unlikely to compete with any other agent that's on board. And so I can totally hear you where this could have come up. So at this time, we would still give sotrovimab to someone who, for instance, received tixagevimab plus cilgavimab. So and just apply the best pressure we can on the virus, as those are very high risk patients, as you might imagine, and at high risk for hospitalization. So we would just basically move ahead with what's best for the patient right now.
Great, and that's also a great reminder that there are those differences between some of the monoclonal antibodies with respect to where they're working or where they're acting. So we've had a couple of questions come in from different audience members asking if you wouldn't mind summarizing the indications for these direct-acting antivirals and the monoclonal antibodies. Maybe what patient populations are we looking to use these in?
Absolutely. So the issues right now are both about what groups did we test these agents in, and then how do we apply it to today's situation, especially when there's limited supply. So going backwards, many of the outpatient treatments, in fact, all of them really predominantly looked at patients who were unvaccinated. So these studies were begun sort of as vaccine were rolling out, or perhaps in settings where vaccine was less available, and then looked ahead to see what the outcomes were. You've already noticed, I kind of alluded to it, for the PrEP treatment or pre-exposure prophylaxis antibodies. Although we tested it in unvaccinated, we did not authorize it in our country for the unvaccinated. Why? It's because this treatment is in such short supply, it is very expensive to make, and there's a much cheaper alternative, which is vaccination. And so for those individuals, we have limited the people who can get it. Another example of how we're limiting is that for treatment, although the population for which it's authorized is broader, then we currently only have enough supply to prioritize patients who are at the highest risk for hospitalization. And so while there are many people, for instance, who are vaccinated but have multiple comorbidities, they can raise up in our prioritization schemes. So it's kind of a long-winded answer to say that these, when especially in short supply, should really be deployed to prevent hospitalization. And so the NIH has given out a sub-prioritization that's based on age and immunocompromise, that especially if you're like 75 and older but have a lot of comorbidities plus immunocompromise, you should rise to the top of the list. And functionally, that's what's happening, especially with our first-line treatments of sotrovimab and the nirmatrelvir ritonavir combination. And the
Thank you
timing,
so much
yes,
for
the timing is important too. I should comment on that. The oral agents do have a 5-day window for application, whereas the monoclonals, although it's best to give early, the windows are up to 10 days. And so again, that is a key aspect of how we are triaging patients to one or more of these therapies.
Wonderful. And that's the perfect segue to our next question, talking about the timing of these oral therapies. The question comes to us from Jennifer, who asks if you could talk about access to these oral therapies and the importance of getting them to people early in the course of infection, but then struggling with perhaps how to access them.
Absolutely. And this has been an issue for access in our country since the beginning of the pandemic, whether it's access to testing, access to vaccines, access to care. And it's very clear that there are groups that are more vulnerable to COVID-19 and more vulnerable to either delays in presentation, delays in access to all of these aspects. And so if one thinks about the 5-day window, I mean, we really do need to have testing available right away as soon as symptoms onset. And so in our country, we frankly are struggling with that our infrastructure for testing can result in delays that can then reduce access to therapies. And again, striking more vulnerable populations with less access to their provider. Unfortunately, we have such a wide disparity in our country where some people have their docs on speed dial in concierge practices and compare that to someone who's uninsured. So many states have really integrated this into the rollout of some of these therapies, such as the pre-exposure prophylaxis. They've integrated ways to enhance the access of that agent. It involves many factors, including patient education and awareness about the availability of such treatments, as well as integration of very culturally competent messages that fit the communities in which we are applying. There is no one size fits all to all of this. And so I really admire all the work that's being done to enhance access and provide equitable access. This also allows me to make a comment about equitable access around the world to these therapies, that just like HIV, hepatitis C, it was the rich countries that were able to deploy these therapies. And if anyone's listening from areas of the world where they do not access these therapies, I think I want to express our empathy and our sort of desire to make this more equitable in the longer run, acknowledging that right now it just isn't.
Thank you for that important message as well. While we're on the topic of antivirals, Birgit wondered if you could review these antivirals and their use in the pregnant patient population.
Yes, this is a great topic, and I'll try to review it the best I can. So firstly, pregnant patients are considered a higher risk group for complications of COVID-19. This has been established through a variety of observational cohorts, and thus is considered in our prioritization schemes. Pregnant women can also experience vaccine hesitancy. And while numerous lines of data from the real world indicate that vaccine would have multiple benefits for the woman, to avoid hospitalization, but also no particular effects on that we're aware of on fetal outcomes, whereas having COVID-19 clearly does have such outcomes. Really, vaccination is our first defense. So, I'd say vaccinate, vaccinate, vaccinate. I think any treatment talk really should have that message as well, that nobody who works treating these diseases would prefer to wait until people get it. We'd love to prevent disease. So secondly, moving on to treatment, I think the really high-risk pregnant women who are much younger than perhaps other populations who are vulnerable for hospitalization, but still vulnerable. It's really like the unvaccinated woman with a lot of comorbidities. And in particular, it's persons with high BMIs who are suffering. And so those could be prioritized for these treatments. And so how would we think about it? Well, firstly, molnupiravir. So that works by error catastrophe and induces lots of genetic changes within the virus, but has host concerns. And while there are mixed data in the in vitro assays, we still have major concerns for pregnancy, and thus in our authorization, it is not recommended, although there are instructions on what to do if for some reason the provider decides to apply to a pregnant woman. And there are also concerns, even just giving to people of men or women of childbearing age. And so the molnupiravir has a condition to not get pregnant and use good contraception for at least through the treatment course and for 4 days afterwards for a woman of childbearing age who could become pregnant. For men, because the sperm progenitor cells turn over less frequently, it's up to 90 days afterwards. Now, this may sound like a lot, but really we're used to this counseling from the days of ribavirin, which uses a very similar mechanism. So essentially, molnupiravir is off the table. Now, ritonavir does have some experience, ritonavir-based boosted protease inhibitors in HIV. And so that could be a treatment that could be available to pregnant women. However, it's in short supply. Remdesivir, we do have use initially through kind of expanded access programs, but now since it's been approved in pregnant women, and so I would feel confident in that drug in use in pregnancy. And then monoclonal antibodies, sure, why not? I mean, there's multiple indications that there shouldn't be any off-target effects on the fetus or the placenta, and could even, if applied late in pregnancy, could even be transferred for instance, an unvaccinated woman. So I think right now we would remdesivir is just less available and less feasible, but we actually have operationalized that for the highest risk patients in our sotrovimab Paxlovid. So that's a very long-winded answer, so I apologize, but really one option is off the table and the other three all depend on availability.
Great, and thank you for summarizing all of the information about options. So we have a couple of folks that wrote in with questions switching back to monoclonal antibodies, and so I'm going to do my best to link these together because I think it would make for a robust discussion. So Lee has asked if you could comment on the reasons why sotrovimab is in such short supply and if there's anything in the works to improve that. And then it links to Ranjita's question of what are the drug manufacturers doing with the monoclonal antibodies that aren't currently effective in the Omicron era, and is there the potential for use of those maybe downstream?
Right. So that's a great question. And why didn't we produce enough sotrovimab? Well, I think the company clearly, once it was authorized, would want to maximize its ability to produce these. It just takes time, and the pipelines are such that we didn't have enough to cover our population. And so I would point out that shortage really comes in the face of other issues, including not mitigating this pandemic perhaps as well as we could. But nonetheless, when we're working in times of shortage, I think it's just a challenge to have the supply on hand. I mean, everyone looked and saw, we can make it through our Delta surge. We have these sort of 3 different antibodies that we can treat patients with. And then suddenly 2 of the defenses sort of went away overnight. And that was just not fully anticipated outcome, although many have been hypothesizing that the virus could take this new shape, so to speak. So, it is just very unfortunate timing that as sotrovimab was being ramped up, we did not nearly have enough to cover the high-risk patients that are coming in. So it's just a very difficult thing. And can you remind me of the second part of that question?
Sure. The second part was because we now have these monoclonal antibodies that have been shown to be ineffective against the currently circulating variant. What are manufacturers doing with those, and is there any hope for use of these maybe in the future?
Yeah, no, it's possible that the next surge, it's hard to mention those words, but could be due to a strain that's more similar to the others. So I think having continued supplies of those agents may be important. But if all we continue to see are sort of Omicron-related virus in the future, then those will likely remain on the shelf. Now, there was some talk, just so people are aware, of why can't we have a point of care assay that then determines whether a patient has Omicron or Delta, and in our country, which were co-circulating, and then use that information to decide what antibody to give. Well, a lot of that had to do with, well, we didn't have an FDA authorized test at the time Omicron struck. There are efforts to develop such a thing to allow use of those supplies. But we just, again, the things just moved too fast to be able to deploy such a countermeasure. So the thoughts were there that we could try to use this supply, but in the end, it became over 98% at our last check a few days ago, when previously we had a Delta surge going on in early December. So it just shows you how quickly things changed.
Yeah, basically, it feels like oh, go ahead.
Yeah. No, basically these are on the shelf in Massachusetts.
Okay. Yeah. Thank you for sharing what's known and what we could potentially do with that. As you mentioned, the information's coming at us fast and furious, and so it'll be, up to us to pivot with what comes next. The next question, switching gears from what we've talked about to date, comes to us from Betsy, who wanted to know about ivermectin, and what are your thoughts on ivermectin, and perhaps why is it still being prescribed by some providers?
So ivermectin has an interesting history through this pandemic. It was first shown to have in vitro activity by a group in Melbourne very early on in the pandemic. However, it was noted by our pharmacologist colleagues that the concentrations needed to achieve that inhibitory concentration were far, far greater, 50 to 100 times than what one can achieve. Now, nevertheless, this is a medication that has been that is produced in large amounts and is present around the world for a variety of treatments of parasitic infections. And so the hypothesis that whether it could work in people, just given that we could repurpose such a large supply, was tested. And unfortunately, some of the early randomized trials just did not showed perhaps hints of efficacy. However, a couple of those trials have been withdrawn as people looked at them closely before they were published and found that there were major issues in terms of the data. And nevertheless, this began a pretty large campaign to deploy these agents. And so, again, as a scientist, you remain open to the possibility that these agents may work. However, just given that the majority of evidence of trials indicate neutral or no benefit, that at this time, that I would not recommend that for patients at all. And so right now, if a patient is interested in ivermectin, there is a way to access a remote clinical trial in the United States called ACTIV-6, ACTIV-6. I should disclose that while this isn't an industry sponsored trial, that I do serve on their data monitoring committee as well, and that's why it wasn't in the, because it's non-industry. But nonetheless, that trial could access in a randomized fashion and give us even more information as to whether that's helpful to patients. And so, and they're very passionate people who believe that ivermectin works, but I would just advise that we take a step back and look at the actual data, and which do not indicate strongly that there's a benefit at all.
Great. And thank you for reminding us all that, we still have ongoing clinical trials and ongoing options to, continue to seek out what treatments may work best or even better for our patients with COVID-19. I think we have time for one last question. So this will be our last one coming from Julio, who asks if there are any special considerations to be thinking about with these treatments for COVID-19 in our population living with HIV.
Yes. So, and that's relevant to a lot of other efforts by, CCO at least to inform about the rapid changes in HIV. And so I think that there are a couple issues I would just bring up. One is should we use ritonavir monotherapy for patients who have unknown HIV status but could have HIV? I think it's generally been judged by most looking at this who know ritonavir well that a 5-day exposure is rather unlikely to produce resistance. And then what should you do for an HIV patient who is on ritonavir already? Well, there's actual guidance on this that you could actually use the nirmatrelvir ritonavir drug on top of the other dose of ritonavir that they're on. If we really rewind in HIV history, we were using doses of ritonavir, that were quite large, much larger than the 100 milligram dose that's used now, or the 200 milligram dose that would be used in combination. In terms of overall efficacy, I'm not aware of specific data to indicate how things work for HIV. We treat patients with HIV and prioritize them because it is a risk factor for disease progression.
Thank you very much to Dr. Kim, and thank you to our listeners for joining in. As a reminder, to view the full COVID-19 Resource Center on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.